We've heard so many times that early detection is the key to heart health. Amy's here with information about a pilot program.
Vicki, the statistics are really startling. Every 30 seconds, an American has a heart attack. Every 53 seconds, an American has a stroke. And every hour, 100 people die from vascular disease. So what if you could be screened to find early warning signs to help you reduce your risk and perhaps even change your fate? That's what a local doctor is hoping to do with information about your circulation. Nashville neurologist Fred Callahan is on a mission.
And that's the reason for screening, to identify early on when the artery is not very narrow, but when the risk is extremely high, so that we might get more Americans in an appropriate program of both medication as well as behavioral change to make our plaques become stable.
His target, this ugly plaque that's the source of so much sickness in America.
CAP keeps the circulating blood for me.
But he believes we're focusing too much on just knowing our cholesterol levels.
High levels of cholesterol are not associated with stroke, and with 40% of all the Americans having a heart attack this year having a normal cholesterol, it's very clear that if every American learns their cholesterol level, we probably haven't fixed the problem. If you can learn that you have hardening of the arteries, that you have plaque, then whatever your cholesterol level is, for you it's too high because your blood cholesterol has gotten inside the artery.
And that's been the challenge, how to find that out in an easy, affordable way.
The next medical revolution is what we call integrated vascular care, and the first step is widespread screening. Because right now, for those people that would like to find if they have vascular trouble, in our country, you can't really get that done. Insurance won't pay for it. The tests are generally quite expensive, and you'd have to pay for it out of pocket.
This screening ultrasound, called AngioScreen, is Dr. Callahan's answer, a non-invasive tool to get images of the arteries.
No radiation, there's no dye that's injected, and we find out very quickly these are actually the very best measures of if you're at risk for a heart attack or a stroke. These measures are better than your cholesterol or your good cholesterol or your bad cholesterol, any of the other measures that we have in medicine. These are better than those.
Patients are given pictures of their carotid arteries to take to their own physician for follow-up.
Good color flow.
The goal, that early detection leads to early intervention.
We think on the medical side that you might be on medications, that you probably should be on medicines, that we can make a difference. We can make that plaque shrink in size. We can make the plaque that might be unstable become stable. We can do this with medication.
It turns out that 10 million Americans, basically 25% of all Americans over 65, have blockages in their leg arteries, and they have a risk of a heart attack equal to the risk of someone who just had a heart attack and survived it, having a second heart attack, even if the patient with the leg artery blockage has never had a cardiac symptom.
If you go through the screening, you should take your information to your own doctor.
This is Fred Callahan from Nashville, Tennessee, and I'm going to share with you today some of the advances in terms of blood vessel screening and some of the newer concepts in medical care that's represented by AngioScreen. And specifically, I want to go through some of the science that was used to determine what we do. The purpose of screening is to identify those of us who haven't been sick yet, but we don't know that our blood vessels are not normal. And then the notion is, if we could identify those Americans, and there are millions and millions of Americans that we'd be able to find, is that we'd be able to maybe change their behavior. And in order to do that, we'd have to have a program that would be understandable. It'd have to be some way to communicate, and this is very difficult, at least in my practice. As a neurologist, I mean, I'll talk, but patients might as well think I'm speaking Japanese. So you have to be able to communicate with a public that is medically illiterate but doesn't wish to be sick. It has to be convenient. And certainly coming to our offices in Fortress hospitals is the very antithesis of convenience. The measures that would be utilized would have to be extraordinarily sensitive. That is, we'd have to have a convenient and understandable way to actually make sure that we were actually measuring what we wish to measure, and that is the not normal blood vessels. It would have to be low cost. If you want to screen literally 100 million Americans, you have to do that at a very good price point, because probably the majority of the people we screen will be normal. So we can't spend thousands of dollars identifying the normal. We'd have to have appropriate educational collateral materials, And I think we ought to be able to provide the public a digital record. Patients have come to my office and they've seen other physicians, they've had testing, and typically they bring nothing with them. And identifying those records and chasing them down is something that's very, very difficult to do. So that would be the ideal screening program, and that's precisely the screening program that was developed for AngioScreen. Convenient, cost-effective, a wonderful way to communicate with patients in order for them to understand that they have risk or accelerated risk, and to invite them to come into a healthcare system that will hopefully care for them, not just rescue them. Typically a consumer comes into the screening suite or screening area and has to remove their socks and shoes. So they have to do this in order to get up on the table. They lie recumbent. They have to be perfectly flat. The head of the patient, the ultrasonographer, is going to study and do both the B mode as well as the color flow image with the carotid, and do the Doppler interrogations and obtain that data. And at the same time, the technician is actually performing cuffing the patient with all 4 limbs, because we have to get 4 blood pressures, then affixing the EKG. We use a very particular way that we do this in order to trigger the interpretation microprocessor, where lead V1 or V5 is actually put over the clavicle. And then we do a Doppler interrogation of the blood pressure in the legs. And often we don't use Doppler over the radial artery in the wrist. We just simply do the usual stethoscope check of blood pressure. And so in very short order, literally in 8 or 10 minutes, we then obtained all of the data that then gets entered into the single sheet that the computer program produces for each subject that comes through screening. And then a period of time is spent with the subjects as they leave and exit the screening area, so that they can have an understanding of the results, how the abnormal results are flagged based upon accepted guidelines with the numeric data. And they're given collateral material so that they might read on their own and understand more of what these measures mean for the individual subject. We use the peak systolic velocity. In most subjects, if the PSV is more than 125, then there's at least 50% blockage in the carotid artery in the neck. And those subjects need further testing in a platform where we do formal diagnostic studies. Blood pressure is so very important for us to check, and we do that in the recumbent position, actually in all 4 limbs. 50% of all the attributable stroke risk on an annual basis is from hypertension. Another way of saying that is, if we controlled America's blood pressures, half of all the strokes in America are prevented by just blood pressure control. The body mass index is calculated by the computer system when the subject gives their height and weight. World Health Organization standards are utilized. The PSV is what I mentioned during the Doppler interrogation of the carotid arteries. This is done by the ultrasonographer. So we have a B-mode image that both has color, so we know where to locate the blood vessel, as well as the black and white or grayscale image that's produced. And then the peak systolic velocity, part of the Doppler interrogation of flow in the internal carotid artery on both sides. 15% of all strokes in America are occasioned or created by atrial fibrillation. Body mass index is a World Health Organization standard. It's a measure for fitness, and it should be 17.9 to 24.9. ABI, as I mentioned, the blood pressure in your legs, is the most sensitive predictor of coronary artery disease of any test we could measure. This is a more sensitive predictor than is measuring white cell myeloperoxidase, total cholesterol, LDL, Lp(a), particle size, LDL, or even high sensitivity CRP. All of those surrogate markers are dead on arrival when it comes to looking at the great sensitivity of ABIs. And finally, we get to ultrasound. If we find that we have plaque, then we know that the blood vessel wall is not tolerating the patient's lipid levels. Those lipid levels are dangerous for them, and they should do something about that. Not that they can do something on their own, but they need to come into healthcare where they can really get that problem worked on before they have an index event like stroke or heart attack. And so these were the measures that we selected because they had been vetted and validated by prospective clinical trials. They're easy to measure in subjects. It doesn't take a lot of time. They have high sensitivity, and it's widely accepted that if we made a modification medically as physicians with these measures, we would do a tremendous job for the public health in America. I live in a vascularly enriched neighborhood in the Deep South. We have more strokes than the rest of America. We have more heart attacks than the rest of America. So a snapshot of those Nashvillians who are not yet sick would show you that they have plaque. Plaque doesn't happen instantly, develops over decades. So you see, this is now a tabulated recitation of what we found. We had 62% overweight or obese, the same number all around America. 28% had carotid plaque. This is plaque in the carotid artery, not just the very minor changes in blood vessel walls. 28% with carotid plaque. 4.4% had peripheral arterial disease. About 2.4% had atrial fib. None of the patients with atrial fib were taking warfarin. 19% had stage 1 or stage 2 hypertension. You'd have expected 25% to have stage 1 and stage 2 hypertension if they had been completely untreated. And yet 3/4 of these subjects were taking medicines. So the combination of obesity at 62%, carotid plaque 28%, and then stage 1, stage 2 hypertension at 19%, represents metabolic syndrome. And 37% of those subjects that came to our pilot project needed a treatment or prescription on the spot. It turns out the majority of those that came actually went and saw a physician. We told everyone, go see your doctor, and if you don't have a doctor, get one. The majority went. The majority of the patients that I saw in my office today won't come back and see me at the appointed time that I gave them. So this is a very, very high touch. This is a great way to communicate with patients. 20% of those who saw physicians had other testing. In a way, it becomes a testing pipeline. 2% actually had a procedure. When we do this kind of screening in a different way with the Heart Association, it's less than 1/10% that have a procedure, because those kinds of other screenings don't have the impact, don't have the power, don't have the ability to communicate with patients like we do with AngioScreen. 4.1% received a new prescription, and again 37% needed that. These are data now that came at 10 months. 7.5% started over-the-counter medicines, probably driven by my book on angiology. 12% increased their exercise program, and believe it or not, at 10 months 18% had lost weight. The ability to have maintained and sustained weight loss over that period of time is remarkable, just from showing images on a single sheet of paper. Our pilot project in Nashville was then followed by a different use of this technology of AngioScreen in a market where we had not been known. So this was done actually in Chicago, in the northwest Chicago suburbs. And a group there that has a 4-hospital platform, the Alexian Brothers, took our program out to the citizens of Chicago. They found immediately they were booked for 3 months, and they went from 1 screening unit to 2 screening units. So that they identified, even out of the Deep South, away from where we have such an enriched vascular cohort, that the public still has a phenomenal interest in this. This was a hospital system that carried it out so they could better care for those patients that they wanted to tie to their hospital system. They found great benefit from doing this. Their doctors have had more patients, they've had more procedures at the hospital. So it's very clear that the pilot project experience and the success that we had in Nashville was easily replicated in the metropolitan market in Chicago. And this system and program will work everywhere in America, and everywhere in America needs it. America wants this. We should provide it.